I really and truly hope I can live up to this. This is my second invitation to this symposium. The first time I was invited, I actually ended up in the hospital with gram-negative sepsis, and I'm glad to say that I learned today I was Sky stage B, and I'm really glad to know my prognosis was good. But thank you for that. When Marwan asked me to speak, I said, I'm not a cardiogenic shock guy. He said, well, speak on what you want. I will try to make my talk relevant to the field that you have given your lives to. You spend a lot of time trying to keep people alive, but after you keep them alive, I think they're now going to create a second class of patients that are vulnerable to develop heart failure, and I'll try to walk you through this. And I want to acknowledge Dan Burkhoff, who's in the audience today. A lot of these ideas came out of a Gordon conference where we literally walked into the woods and we were unhappy with what people were saying. And so we sort of bantered ideas around. And sort of over the last 8 years, these concepts have evolved. And to me, they're fairly clear, and I hope to be able to impart them to you today. So as we've learned today, we've become incredibly good at treating patients with heart failure with a reduced ejection fraction. Shown here in this cartoon is a normal heart that after injury, the heart dilates and the walls thin and the patients develop symptomatic heart failure. As I said, we've become exceedingly good at treating these patients with medical and device therapies, and they're really largely three outcomes. I'm going to simplify this, obviously. There's a group of people who have a full recovery of ejection fraction and normalize their hearts. There's a more common group of these partial responders who will increase their ejection fraction between 40 to 50%. And then there's a group of people who really never have a functional response, end up going on to transplant and LVAD. I'm really going to focus in on this group of patients who have a recovered EF, and it's become a really interesting group of patients. And actually, I think there's a distinct biology with these patients, and it opens up new forms of therapy, which is actually what we're studying in the lab. Now, if one looks in the literature at this heart failure with a recovered ejection fraction, the nomenclature is incredibly messy. People have called it heart failure improved, heart failure with preserved ejection fraction because the EF is oftentimes greater than 50, borderline EF, heart failure with a recovered EF, heart failure with mid-range EF. The definition is even muddier. Some people say the increase in ejection fraction has to be greater than 5%, some say 10%. Some insist on normalization of the ejection fraction, others insist that it's a different number. Unclear clinical course and unclear biological substrate. There will be coming out in JACC a consensus statement from a number of authors, and what we've tried to encourage is that we call this heart failure recovered EF. I like the R because it implies that it came from reduced EF. We suggest that the EF has to be greater than 10% increase and that the EF has to increase greater than 40%. But again, these are consensus guidelines or statements, but they're not supported by data. This is a slide that I stole from my good friend Marv Konstam, and what it really illustrates here is that when we're talking about ejection fraction, no matter what the cardiac output is, it really is an indirect reflection of the end diastolic volume because of the way that we calculate ejection fraction. So as the heart gets bigger, because of the way we calculate it, the ejection fraction drops. Conversely, when the ejection fraction improves, it means that the hearts are actually getting smaller. I want to touch briefly on the epidemiology of heart failure with a recovered left ventricular ejection fraction. This is a wonderful slide by Ken Margulies where he just talks about the groups of different kinds of insults that can affect the heart, and these patients will all undergo a spontaneous recovery of ejection fraction. So starting in the bottom, there's abnormal energetics. I think the classic case of this is a tachycardia-induced cardiomyopathy. Toxic insults, when I was a house staff, it was mainly cocaine and alcohol. Today we see it a lot in chemotherapy. And then what we studied in the lab a lot is inflammation and the fact that once inflammation resolves, that the ejection fraction will improve. So with Mike Gevirtz, we went through the entire literature of the spontaneous recovery of ejection fraction, and we tried to just really break out two things. One is who improved ejection fraction greater than 10%, and then second, who actually normalized the ejection fraction. So shown in the blue bars in the back are patients who improved ejection fraction by more than 10%. So if you just look all across the different etiologies of this, most patients will improve their ejection fraction by 10%. If you look at the SIRS, which is probably most directly applicable to what you deal with cardiogenic shock, you can see most people will improve their ejection fraction greater than 10%. So recovery of EF is really a broad-based phenomenon across all forms of cardiac injury. More interestingly, if you look at the red bars in the front, you can see that they tend to go down as one proceeds from the left to the right. So energetic hits to the heart, which are really short-lived, really allow the heart to completely normalize ejection fraction. Things that are associated with inflammation or a lot of end organ damage like SIRS or myocarditis, although they improve EF more than 10%, they don't normalize their ejection fraction. And this is important when one considers why people will develop heart failure after they've improved their ejection fraction. This slide just briefly summarizes all of the FDA-approved therapies that actually have been demonstrated to improve ejection fraction and also reverse remodeling. So whether it's ACE inhibitors, beta blockers, ARBs, LVADs, or CRT, in each case, the ventricles get smaller and the ejection fractions improve. Jim Udelson has done a really nice study and shown that the amount of remodeling directly correlates with improvement in morbid mortal outcomes in patients with heart failure. So somehow, when the ejection fraction improves and the heart gets better, patients do better. So take-home message number one is that once the inciting stress is removed, recovery of ejection fraction is the rule rather than the exception. When we give beta blockers and ACE inhibitors and ARBs and sacubitril valsartan, we're in essence removing the inciting stress of the neurohormones. And the other important take-home message is that although recovery of ejection fraction occurs frequently, the normalization of the heart occurs far less frequently. So what about the durability of this left ventricular ejection fraction? I've shown you now that these therapies will improve ejection fraction. And at the time that Dan and I were kicking this around, these data really weren't available. And subsequent to when we sort of put out this concept of remission, there were a series of studies that began to appear in the literature which really supported the idea that even though the hearts look normal, they're not normal. So this is a slide from Bazare. What they did was take the Penn database and they looked at people who completely normalized ejection fraction, heart failure reduced ejection fraction that improved, normalized greater than 50. There were a group of people who had heart failure preserved ejection fraction, and then a group of patients who had heart failure reduced ejection fraction. So the first thing you see in the purple line is that if you improve your ejection fraction, you do far better than the green line, which is heart failure reduced ejection fraction. But if you look over on the right-hand bar, you can see that the group of patients who recover their ejection fraction have the same hospitalization rates as the patients with heart failure preserved ejection fraction. So even though you normalize ejection fraction and the hearts get smaller, you still continue to have heart failure events. And I think that was the thing that was difficult to reconcile. Another really interesting study came out of the group in Italy, Merlo and colleagues. They had a very well phenotyped group of patients with dilated cardiomyopathy, so absolutely no chance of intermyocardial infarction. And they went into their database and they said, okay, among the patients that we have with dilated cardiomyopathy who are treated, how many completely normalized ejection fraction and completely normalized size? And shown in the red bar on the top, about 15% of their cohort actually completely got better on medications. So we in white coats would say that they're cured. But if you follow these patients out long term, you found that about 60% of them remained free from hospital events, but another 40% actually continued to get sick. So again, this concept that although these hearts look normal, these patients are continuing to have heart failure events. And this is a more recent study that was in JACC. It's following patients that were in Spain, a single center medical center. But you can see on the left that patients with recent onset cardiomyopathy in the blue end up doing much better in terms of improving ejection fraction than people who, I think these are the ischemics versus the dilateds, I'm sorry. But the important thing is you can see there's a downward tilt in the ejection fraction after these patients have been on medicines for a long time. So I've just shown you sort of 3 epidemiologic studies now that point to the fact that even normalization of the heart doesn't mean that you're free of heart failure. So the observation that heart failure occurred in patients with normalization of LV structure was totally irreconcilable with everything that I thought I knew about heart failure biology. I had sort of always been taught that if the heart got small and the ejection fraction improved, it was game over and you could go home and claim victory. And this is from one of Jay Cohn's famous consensus statements that although remodeling is generally accepted as a determinant of the clinical course of heart failure, slowing or reverse remodeling has not until recently been recognized as a goal. The second thing that in a number of leading textbooks in the field all indicated that reverse remodeling was synonymous with resolution of heart failure. The problem is I wrote all these chapters, right? And then the other thing I've learned is that you can't really drink your own Kool-Aid. It leaves you hungover, confused. And for me, it was really confusing because all these years I had sort of always thought that was the holy grail, was the reverse remodeling, the improvement in ejection fraction. So this is where Dan and I literally walked into the woods. It was at a Gordon conference, and the LVAD mafia was running around talking about recovery, and I, over a glass of wine, I looked at Dan and I said, "Do you really think recovery exists?" And he goes, "Hell no." So we went out and we talked about this, and so it really raised the question, is there something different about a heart that gets small and contracts normally, but redevelops heart failure, and then a heart that actually gets small and contracts normally, and you never see them back in clinic again? And this is where Dan and I went back and forth, but I wanted a way to sort of demarcate those ventricles that are at risk of developing heart failure. We basically called that myocardial remission. And we insisted that the hearts that got better and never went back into the heart be called recovery. And actually, this has been embraced now by the LVAD mafia, in part. And actually, there's an NIH statement on this. So at the time that I proposed this, it was actually at the UCAR's Recovery Symposium. So I first brought these ideas out, and I walked back to David Cass, who's a really great investigator. He was sitting in the back, and I said, "David, what'd you think?" And he goes, "You've just stuck your head in the lion's, you just walked into the lion's den." And so this got me like a 7-year or 8-year ban from the UCAR Symposium. But I've been allowed back in now, and we've all made up. But the concept, again, these were just sort of all concepts, and they didn't really reconcile with what we thought we knew about heart failure. So I'm just going to walk you through why this is biologically, and then I'm going to try to make this relevant to cardiogenic shock as best I can. So when I think about remodeling, I think about the myocyte, I think about the matrix, and I think about the chamber. So this is a study where we looked at RNA transcripts using single RNA-seq, which allows us to look at single copy genes. And I don't want to make this harder than it is, but if you just look at the number of genes that change in a failing heart and a recovered heart, and then you sort of look at the differences, just look in panel C, you can see that the patients with a heart failure are shown in blue, the patients with non-failing hearts are shown in red, and you can see the patients who have reverse remodeling that on an LVAD or somewhere in between. So the concept here is that you don't completely normalize your gene program. You get better and you actually contract better, but you don't completely normalize it. And that's shown here in this slide. When I think about the myocyte, there are a number of different compartments of the myocyte. I don't want to bore people with all the biology, but if you look to the right, you can see that for each of these so-called modules, what we call modules of the myocyte, most of the genes remain persistently abnormally expressed, despite the fact that the heart is getting better. And this is just sort of summarized here in the bar graph. You can see that most of the genes that remain persistently dysregulated in all aspects of the myocyte, the only genes that really come back are sarcomere genes, and that, I think, explains in part why they contract better. This is a really wonderful study by Amrit Amberdecker. What they did was to take single isolated myocytes from human hearts. They looked at non-failing hearts. They looked at myocytes that were taken out of failing hearts before VAD, and then they looked at the same hearts and myocytes that had been isolated after VAD. And what they did is you can take these individual cells, strip the sarcolemma off, and then expose them to calcium, and you can actually look at the force between these two tweezers of how a myocyte contracts. So the non-failing hearts contract about 15, 17 nanometers of force. Failing hearts obviously reduced in green, and then the hearts supported with the VAD actually come back, and the myocyte strength comes back. But if you notice, it's still significantly less than a non-failing heart. Again, the concept these hearts come back to a different steady state that's partially normal but not completely normal. If one just looks at the ultrastructural changes, if you look to the far left, you see the really crisp sarcomere registration. If you look in the middle, you see that's completely lost. If you look to the right, post-LVAD, there's a partial restructuring, if you will, of the ultrastructure of the heart, but it's not the same as you see in completely normal hearts. Myocardial alterations, again, this is where Dan Burkhoff and his group have made a number of important contributions. In the failing heart, a lot of the collagenolitic enzymes that degrade collagen are actually activated. During LVAD support, it's partially normalized, and what Dan's group showed really nicely was that for complete normalization, you really have to put the people on ACE inhibitors and guideline-directed medical therapy, and that helps the heart, at least the matrix, to normalize in part. And then the last thing is that we always think that when these hearts get smaller, they're normal. And there was another person, I don't think it was Dan's paper necessarily, but I think it's one from his group. And this just shows here that when you have a dilated heart, you have both meridional and radial wall stress. As the heart gets smaller and the diameter gets smaller, you reduce meridional wall stress. So just by getting smaller, you unload the heart in essence. And this came from a study where they looked at failing hearts. They did pressure volume curves on human hearts before and after LVAD support. And you can see that the failing hearts in panel A, the pressure volume curves are shifted all the way to the right. If you then put them on an LVAD, the pressure volume curves completely normalize. They're the same as non-failing. And again, we would claim victory on that. But if you look carefully at the R to H ratio, that's that middle panel with the orange bar around it, the R to H ratio, which is the wall thickness to the radius, it's a poor man's measure of wall stress, they don't normalize the wall stress. So even though the heart comes back to a normal pressure-volume relationship, the walls don't really ever become thick again, so they can't normalize wall stress. So now there's a myocyte that has an abnormal gene program. There's a myocyte that can't contract as well, and then you have a ventricle that can't normalize wall stress. It's really no surprise that these hearts redevelop heart failure. So take-home message number 4 is that reverse remodeling is not simply a mirror image of the molecular pathways that become dysregulated during heart failure, but rather the reverse remodeled hearts, they come back to a new steady state, which allows the heart to actually function. But I think that new steady state has elements of heart failure and it has elements of a normal heart, but it becomes more vulnerable to each subsequent hemodynamic stress that it faces. And so I've tried to illustrate this in this cartoon here, and it just took years because for me as somebody who's taking care of patients, when you see the heart contracting well and you see its normal size, you think that they're cured, but that's not the case at all. So Dan again was kind enough to send me this, I think this was a European meeting, it's the TREAD-HF study, and when I saw this I said, okay, we're right. What they did in this study, and I have no idea how they got this past an IRB, they looked at people who by all means had completely normalized LV structure and function, normalized NT-proBNP, and then they randomly assigned them to stay on guideline-directed medical therapy or take them off medical therapy. And the primary endpoint was really a relapse, which they defined as a decrease in EF by greater than 10%, increase in volume by 10%, or a 2-time rise on the NT-proBNP. Well, within 6 months, about 50% of the cohort promptly redeveloped heart failure when they took them off the heart failure meds. And panel B just shows what actually went wrong. So it was ejection fraction size and the NT-proBNP. Those are the different elements of failure. But I was really delighted in the discussion. I didn't actually review this, but they said these findings suggest that for many patients, improvement in cardiac function following recovery of EVF does not really reflect a sustained recovery of heart failure, but rather reflects a remission that they have to continue therapy. So again, I think this concept that we've been trying to put forward of remission is actually real. The interesting thing is there's a biology to it, and we're trying to develop new therapies that directly attach that. And again, as somebody who studied myocardial homeostasis, it was difficult for me to reconcile this, but the concept of robustness is different than homeostasis. And robustness says basically biological systems are constructed to take a hit and keep on functioning, but that doesn't mean that the second steady state they come back to is necessarily robust. And so if you look at circle 1 in homeostasis, if you get injured and you perturb function and you come back to normal, that would be called homeostasis. I think what remission is you transition to the second steady state 2, which, as I've shown you, has elements of heart failure. The heart looks partially recovered, but not normally. And these hearts, if you then stress them either with a hemodynamic load or angiotensin and phenylephrine, at least in mice, they decompensate and develop heart failure. So I realize that I'm a little over time, but I will tell Marwan that when I first got my sheet of responsibilities that they gave me an hour for this talk, so I really cut 40 minutes of it off about 30 minutes ago. So I want to briefly touch bases and try to bring this back to cardiogenic shock. So some of this is relevant to what we talk about today. So I had the pleasure of working with somebody named Richard Hotchkiss who was interested in sepsis, and he's the nicest man in the world, but somehow he convinced family members to let them pull all the organs out of their loved ones the minute they became dead. The minute they took them off the ventilator, he went in and opened them up, took kidney, liver, and heart. So he had all these hearts in the refrigerator, so I said, okay, what I want to do is do transcriptional profiling. And I showed this thing here because Bill O'Neill had talked a lot about inotropes. This just talks about the demographic characteristics. But if you look here, virtually all these people, to keep them alive, were on at least 1 to 2 inotropes. And when I show you the transcriptional profiles, you'll understand why these drugs are so potentially deleterious. So we again did transcriptional profiling. The yellow circles show ischemic heart disease versus normal, and dilated versus normal. But look at the orange hearts and how many genes are abnormal and are distinctly abnormal in these septic hearts. And if you look at the PCA plots shown in panel B, they're completely different. I have been torturing mice for 30 years and knocking in genes and knocking out genes. I've never seen anything like this. It's really molecular Armageddon in the heart, in these septic hearts. And so if you look at just the genes that are abnormal, I know that Dr. Rami is very interested in metabolism in these failing hearts. If you look at just the changes in the mitochondrial, all aspects of mitochondrial function are severely downregulated. I don't care whether you feed this heart glucose or ketones or fatty acids, it's not going to metabolize anything. The whole metabolic machinery is shut down. And then we also looked at the sarcomeric genes, and they also get shut down in septic shock. And I don't have data on cardiogenic shock, but these are the only human data that I'm aware of where we're actually, at the time the patient dies, we were able to look at transcriptional profile. And the hearts are completely reprogrammed. They make heart failure look normal. They're so sick. So I think it's I've never seen anything like this. So take-home message number 5, septic shock hearts are really a mess at a molecular level. And I don't have any data on this, but the natural history of recovery of EF in this patient population and in the patients that you try to save, I don't think we really know that. But based on first principles, I think these patients are at risk of developing heart failure in the future. So I want to wrap all this up and try to bring it home and make it relevant to what we all do as healthcare providers. We've known about remission for a long time. I think the formalization of the idea, I think, was important. But just shown here, this is from Lynn Warner Stevenson. There's this initial admission to the heart, at least for recovered EF, for reduced EF, it's what I call forward remodeling. We then institute medical and device therapies. Patients stabilize, and they stabilize for a while. But eventually, as I've tried to show you, they're all coming back in the hospital, and it's a new biology. These patients become refractory to standard neurohormonal therapies, and we don't really have any idea what this is about. And as I said, we're trying to develop new therapies in this space because there's a distinct biology for it. And we've all seen these curves before, so at some point in time, even stable patients become unstable, and the times of remission become shorter and shorter, and eventually they develop intractable heart failure and unfortunately pass away. So why do I care so much about this stuff? So we talked a little bit about reimbursement. So today, healthcare systems are being punished for readmitting patients to the hospital, and we're being told that we're bad doctors. I don't think we're bad doctors. I think we're dealing with really bad biology, and so the way that the Congressional Billing Office comes up with something is, does it score? Is it cheaper? And the whole 30-day readmission had nothing to do with heart failure biology. It has everything to do with saving money. And so this is my second to last slide. I'll be done in a second, Vijay. But the importance of this is you can see in the upper curve that heart failure admissions are actually going down because of these policies. But conversely, heart failure mortality is actually going up. And I really worry that the current policies of keeping people out of the hospital when they actually have biology that needs to be admitted and taken care of, it's really the wrong thing. And we as a community need to stand up and shout about this. So I'm going to end with this. One of my favorite Winston Churchill quotes. Now, this is not the end. It's not even the beginning of the end, but it is perhaps the end of the beginning. I think we've made tremendous progress in the field of heart failure, and we've really gotten to a point now where we can stabilize the disease, but now we're facing a new challenge, which is to understand why these people who we thought were cured end up still with heart failure. Thank you very much.